So I'm going to be talking about renal masses and cysts and how you classify them and analyse them. We come across a lot of these, and the thing to decide, first of all, is it a solid or is it a cystic masses? I'm going to talk about the CT evaluation of solid renal masses. I'm going to talk about other modalities, and if we've got time, we'll go into the Bosniak classification. A lot of these are detected incidentally on ultrasound, CT or MRI. Virtually every patient comes in at the hospital these days and has some form of cross-sectional imaging. So you need to decide, is it a solid or is it a simple cyst? This is very easy to determine on ultrasound and MRI, but it's not always straightforward on CT. So simple cystic masses are obvious on ultrasound. They've got fluid signal on MRI, the high signal on T2 and STIR. On CT, they're less than 20 Hounsfield units on a non-enhanced CT, and you might need to confirm that. The 20 Hounsfield units is not always absolutely categorical and might need to be confirmed with ultrasound or MRI. Anything more complex needs a Bosniak classification, and that's purely for cysts, not masses. Simple renal cyst, through transmission, no septi, no nodules. On CT, a non-enhanced CT, you can see it's got a density of 2 Hounsfield units. Gallbladder is 4, so very similar. On a STIR sequence or a T2 weighted sequence on MRI, very high signal. This patient's got polycystic kidneys. You know this is T2, fluid weighted, because you've got high signal in the CSF, high signal in the gallbladder, hepatic cysts, and fluid in the stomach. On ultrasound, we've got a simple cyst with a single septum, a thin single septum you can just forget about again. So the decision you need to make is it a simple renal cyst with a single, or does it have a single non-complex septum? If it does, you can forget about it. If it's a complex renal cyst, you need to do something further. You need to evaluate it with CT and give it a Bosniak classification. If it's a solid mass, Bosniak classification does not apply, but it will need some form of contrast examination. It's usually CT, but it could equally be ultrasound or MRI. That's your first basic decision to make. The things we come across you know all about. The commonest things are renal cell carcinomas, oncocytomas, indistinguishable, angiomyolipomas. Less commonly, we see metastases, lymphoma, infection, focal nephritis and abscesses, which can of course form masses. Other things that can look like renal masses, particularly on ultrasound, are the column of Bertin, the cortex going down into the medulla, persistent fetal ovulation, dromedary hump, particularly on the left-hand side, and focal infarction can sometimes look like a mass. So how do you evaluate these small renal masses, solid masses on CT? You need to know, does it enhance? Does it contain fat? Is there calcification? 3 basic things. So we have a CT renal mass protocol. This varies from centre to centre, but generally there must be a pre-contrast scan. All the scanners these days produce nice thin slices, 1 millimetre or less. You need a post-contrast scan. Optimally, this is in what we call the nephrographic phase, which is 90 to 100 seconds. Sometimes scans are done in portal venous phase, which is about 70 seconds more commonly. That's okay for most of our applications, but sometimes that's too early to analyse renal masses properly. Arterial phase scan is useful, particularly if Mr. Thomas is saying he wants to do a partial nephrectomy and wants to see where all the vessels are. And you can do some nice, elegant coronal and sagittal and even 3D reconstructions if you feel that's helpful. The thing that's really important is it's vital that the pre- and post-contrast scans are performed with the same tube current, same kV on the scanner, and same slice thickness. The reason being is a pre-contrast scan is often done as a CT KUB in some centres. This will be with a low kV and a low MAS. That is not directly comparable with a post-contrast scan when you're measuring enhancement in Hounsfield units. Some masses will obviously enhance, but when it's a borderline enhancement and the scan parameters are different between the pre and the post, you cannot analyse it properly. Pre-contrast scan, renal mass is not obvious. Arterial phase, you can see peripheral enhancement. Nephrographic phase, the renal mass, although it's vascular, is not as vascular as the renal cortex, and you can see it's got lower attenuation. So what you need to look for on the pre-contrast scan, you need to get your baseline assessment. So you need to measure the density of the mass non-enhanced. Look for the presence of fat. If you can see fat, most of the time you can forget about the lesion, discharge the patient. There are exceptions which we'll talk about. Calcification is also important. So a cystic mass generally will have a non-enhanced density of less than 20 Hounsfield units. I say generally, occasionally solid masses can be of lower attenuation. If you've got any doubt at all, confirm it with ultrasound or MRI. So what's enhancement? We keep talking about this. It's iodinated contrast injected intravenously, as I'm sure you know. It circulates around the body and is taken up in any vascular tissue. That applies all over the body. The take-up and the washout is dependent on the vascular supply and the nature of the tissue. Tissue that enhances takes up the contrast, it gets whiter and it's more dense on CT. And this is measured in Hounsfield units, named after Sir Godfrey Hounsfield, who invented CT. Unequivocal enhancement is 20 Hounsfield units. The difference between the pre-contrast and the post-contrast, it's got to be 20 Hounsfield units or more. If it's more, we call this a surgical mass. I say surgical in inverted commas because it could be ablated or you might do nothing about it. If it's indeterminate, 10 to 20 Hounsfield units, you have to decide whether you're going to follow this up, if it's appropriate, or image with another modality. That could be contrast-enhanced MRI or ultrasound. If it enhances by less than 10 Hounsfield units, this is a forget-about lesion. This is due to beam hardening artifact. The CT scanner reconstruction algorithm means that when it goes through dense enhancing tissue around the lesion, it hardens the beam, and that gives you artifactual high Hounsfield units measurements in the lesion you're trying to measure. So you can get beam hardening, particularly in very small lesions. So things you can forget about, as I've said, simple cysts, less than 20 Hounsfield units, less than 1 millimeter thick septi, no nodules. Small fat-containing masses are almost always AMLs. Enhancement less than 10 Hounsfield units is not enhancement, you can forget about it. Typical bright lesion seen on ultrasound, maybe an AML, could be a small RCC, confirm it with a non-enhanced CT, obvious fat, same density as the perinephric fat, same density as the fat around the edge of the patient. Same again here, there's a small AML on the left-hand side. I don't even bother giving contrast to these patients, we discharge them. Again, multiple AMLs, this is a patient with tuberous sclerosis. You can see the enhancing tissue here, fat within them. Again, multiple AMLs, bilateral, this patient's got tuberous sclerosis. The more sharp-eyed amongst you who should have been radiologists will see the large AML around the cortex here, same on the left-hand side. And the clue to this being an AML and not a liposarcoma is the notch in the renal cortex that shows that this has got a renal origin to it. Again, subtle lesion on the right-hand side here, the right-hand kidney, possibly something seen on the pre-contrast scan. You're comparing pre and post, let's zoom in on it. I think there's something there. Measure the density on the pre-contrast scan, it's a bit low. And if you do what's called a pixel map, where it shows you the individual density of each pixel, you can see it's minus 28 here, minus 28, minus 23, minus 23. This lesion contains fat, and this is a lipid-poor AML. These can be difficult to differentiate sometimes. Multiple AMLs on ultrasound, they're bright, very easy to see. On MRI, we can do chemical shift imaging. So what we have here is in-phase scan and an out-of-phase scan. And what happens in the out-of-phase scan is any voxel that contains pixel, any voxel with fat and water, lose signal. So you get a black rim. We call that the India ink sign. You get a black rim around anything containing fat. So you've got it around the kidney, and you've got it around the small lesion within the kidney, which is, of course, an AML. The other sequences you can do on MRI are a fat suppression sequence, where the whole lesion containing fat will go down in density. This is what I don't like to see, and we see this in our MDT not infrequently. There's an enhancing solid renal mass arising from the left upper pole cortex, was the report for this scan. How do you know that enhances? You've got no pre-contrast scan. So let's do the pre-contrast and the post-contrast. On the pre, 98 Hounsfield units. On the post, 96 Hounsfield units. So it hasn't enhanced at all, and this was dense on the pre-contrast scan. This is, of course, a hyperdense cyst, which could be confirmed on ultrasound. The problem with the post-contrast scan is sometimes we don't have the pre-contrast, we only get the post-contrast scan. In this situation, if the patient's still on a table, we can wait 15 minutes, scan the patient later, and measure the washout. And if we see a drop in density of more than 15 Hounsfield units, de-enhancement, it's a vascular lesion, it's a surgical lesion. Alternatively, we get the patient back and we do a proper pre- and post-contrast scan using the same parameters. The other options are ultrasound or MRI. This is a small renal mass seen on ultrasound. I'll just show you contrast ultrasound here. This was done some years ago. So bubbles are injected, and you can see the mass here taking up bubbles, as do the veins within the liver here. So that's a vascular mass, and that's a surgical mass. This is extremely sensitive for flow, as is MRI. Here's a mass, pre-contrast density 58, post-contrast density 73, indeterminate in Hounsfield, 15 Hounsfield units. So let's do an MRI. Pre-contrast, very bright. Post-contrast, still very bright. So MRI, it's the same thing applies. You need a pre-contrast and a post-contrast scan. You can measure this. 406 arbitrary units pre, 392 arbitrary units post-contrast. So this hasn't enhanced. So on MRI, we're looking for a change in value of approximately 30% to say whether something's enhanced or not. And MRI and contrast ultrasound are actually more sensitive than CT for measuring enhancement. Here's a non-enhanced scan for CT done for renal colics. This is the exception to the fat rule. So there's a bit of fat here, there's calcification. Fat and calcification together ring alarm bells for me. Here's the post-contrast scan. Biopsy showed this was a clear cell RCC. And of course, when you see calcification and fat, you think about RCC. So in summary there, surgical masses are vascular. They enhance by more than 20 Hounsfield units. 10 to 20 is indeterminate. And these generally turn out to be RCCs or oncocytomas. Here's an example. This is from my ablation list 2 weeks ago. 48 Hounsfield units pre, 112 Hounsfield units post-contrast, so a definite surgical mass. Here's another one. Clear enhancement in both cases. Large renal mass. It has almost a spoke appearance to it with possibly a central scar. This did turn out to be an oncocytoma, but I will say, and I keep telling our trainees, you cannot diagnose these on imaging, and indeed histologically, as I'm sure you know, it can be very difficult to differentiate between oncocytoma and an RCC. Now, I think we've got a few minutes to talk about cystic renal masses and the Bosniak classification, which causes no end of trouble to people, me included. Whole range of renal cysts here, whole range of classification from simple cysts all the way through to cystic carcinomas. These are classified fairly arbitrarily in some cases on the Bosniak classification. It's a way to try and make what is a subjective thing objective. And of course, like a lot of radiology, there's a lot of grey areas. It's based on the presence of septi, calcification, wall nodularity, and enhancement within the lesion. They've thrown in a Bosniak 2F in the middle. We'll talk about that in a moment. Bosniak 1 and Bosniak 2 renal cysts have pretty much a zero incidence of malignancy. 3 and 4, much higher incidence of malignancy. 2F is somewhere in between. And the F stands for follow-up. Those are patients who follow up. So simple cysts, it's the classification I never use, Bosniak 1, I just call it a simple cyst. Thin walls, hairline thin wall, water attenuation, doesn't need anything doing about it. Simple cysts on CT here. Bosniak 2, again a benign cystic lesion. There can be perceived enhancement within a thin septum, not measurable. This is difficult because on modern CT, I would say virtually everything is measurable. You can have some calcification. Hyperdense cysts also come into Bosniak 2. Again, small hyperdense cyst here, Bosniak 2. Bosniak 2F. F could stand for fun or follow-up because we're going to have fun with a lot of these cases. They can contain multiple septi. They've got perceived but not measurable enhancement. There can be slightly thickened wall, no enhancing solid soft tissue components, and intrarenal hyperdense cysts fall into Bosniak 2F classification. Here's a cyst here on CT, possibly enhancement there. On MRI, it clearly does enhance. Bosniak 3, these are similar to 2F, but you've got measurable enhancement. And I would argue that a lot of what used to be 2Fs we now call 3, because you can actually measure enhancement if you zoom the image in enough. These also are complicated hemorrhagic or infected cysts come into this classification. This is a Bosniak 3 cyst. There's a suggestion of a nodule in the wall. Post-contrast, a very obvious enhancing solid nodule. This is a Bosniak 3 cyst. This needs to be removed. Here's another one. Possibly something going on here. Post-contrast, you've got measurable enhancement within the wall of that cyst. Pre-contrast MRI, no evidence there of a nodule, but there's a prominent enhancing nodule. The same on CT, there it is there. So again, This is a surgical mass. BOSNIAK 4, this is a classification I don't tend to use. I just call these cystic cancers. These are very obviously got enhancing component, thick walls, solid tissue. Here's an example here on ultrasound. You would see Doppler flow within this on ultrasound, which shows flow within it. So you don't need a pre and post contrast scan to prove that that's vascular tissue. Here's an example here, pre and post contrast, the axial and coronal slices, obvious solid enhancing nodules. I'll just quickly whiz through one of our problematic cases. We get these not infrequently, polycystic kidney disease. Where's the mass? I'll go back up. I'm sure you saw it. It's in the middle there. These can be very difficult to work out. This was missed in another centre. Patient came back 6 months later, had a follow-up scan, and there was an obvious enhancing mass. And that patient had a nephrectomy, and they were fine. Things like this, obvious renal cell carcinomas with tumour thrombus going into the IVC, going all the way up into the gonadal vein and the adrenal vein. You don't need a pre and post contrast scan for these. These are barn door cases. There's nothing subtle about them. So in summary, you need to look at and decide, is the mass solid or is it cystic? If it's a simple cyst, ignore it. If it's a complex cyst, classify it with the BOSNIAK classification. If it's a solid mass, look for fat, and if it's got fat, you can ignore the vast majority of these. If it's got measurable enhancement done with the correct technique, with a pre and post contrast scan, that's what I would call, in inverted commas, I must emphasize, a surgical mass. Thank you very much.